Okay, so we're recording now. Again, welcome. Thanks to all of you who are joining. Appreciate you taking the time. Hopefully we'll be able to get through this today. Like I said in my email, I don't know that we'll get through all the material before 5. So if you want to stay over after 5 and do some of the practice questions with me, you can, but don't feel like you have to. But we'll see what we can get through. So let's see, so this is the pediatric test plan, again, that it shows in their handbook and all the things it says that the exam covers. So pulmonary is 18% of the test. So out of the 150 questions, it's 27 questions. And I've highlighted on here apnea of prematurity just because that's an addition from the 2015 test plan. So everything else on here was already on the test plan before. But they've added apnea of prematurity, which I'm sure used to be, is on the neonatal pediatric or neonatal CCRN. And for some reason, they thought they should add it to our pediatric one as well. So we'll go over a little bit about that because in going through their practice questions, I did see a few on that. So. And then this is the testable actions that they say they cover. So covering artificial airways, airway clearance, chest tubes, high frequency oscillator, mechanical ventilation, all the non-invasive pressure ventilations, prone positioning, respiratory monitoring, gases, and thoracentesis. So we'll start out like we did with cardiac with some just basic anatomy and physiology, understanding all of the basics and how things should function is going to help as you're trying to work through the questions on what's going wrong. So first of all, this is the respiratory system itself, and I'm sure we're all pretty familiar with it, so I'm not going to drill down into it too much, but you start off with, air coming in through the nose or mouth, going down past the epiglottis and the larynx into the trachea. You're branching off into your right and left main stem bronchus, and it doesn't show on here, but the little point of the branch is called the carina. Branching off into the main bronchuses, smaller and smaller to the bronchioles until eventually you get down into the alveoli. And that's where gas exchange occurs. So these little pockets of air, ideally air, that your oxygen and carbon dioxide are going to diffuse across into the capillary bed. So, and then you've got, your heart in between with all that we talked about last week of your pulmonary arteries coming in, pulmonary veins coming back, and then your diaphragm that's helping you breathe. Some pediatric considerations, there's a lot of ways in which babies and kids are different than adults as their airways grow. But they do start off with a fixed number of airway branches at birth. So they start off with that, already all those branches in place, they just grow in size. But they do have a decreased number of alveoli, and their alveoli are going to be relatively smaller. And their airway branches are going to be relatively smaller as well. But their alveoli will grow as they age. They're going to have, again, smaller airways. So, and we'll kind of show some diagrams of this in a minute, but relative to, an adult, their airways are smaller, which means swelling and mucus and things are going to affect them more than they will an adult. They have kind of a cylindrical chest wall to start out with until it grows. And in general, their respiratory center is going to be immature. And I don't know if that was an email that I needed, but so especially babies, they're going to have that immature respiratory center, and as they grow, that will mature and start functioning like it should. So upper airway, you might have remember this from nursing school, but babies are obligatory nose breathers. So up until 6 months or so, they really are going to prefer breathing through their nose. It doesn't mean they can't breathe through their mouth, but it's just not going to be natural for them. They're going to want to breathe through their nose, and there's going to be any increased resistance in that nasal passage going on to their airways is going to increase their work of breathing. So that's why our babies that come in with, viral pathogens that are causing all that congestion, it really affects their work of breathing because they don't automatically compensate with breathing through their mouths. Their larynx is going to be different. So their epiglottis is in general longer, it's floppier, it's more anterior. Which is why we use a different, shaped blade to intubate them with, kind of to pick floppy epiglottis. Their cricoid cartilage is going to be the narrowest point. So whereas the vocal cords are the narrowest point of an adult. Just below that, the cricoid is where their narrowest point is, kind of makes a funnel shape, and their vocal cords are just going to be more rigid than an adult. And the trachea, it has the diameter sizes here, but I'll kind of show you in a minute why that's important. So this is a picture of the differences of adults and peds. So like you can see, their tongue is going to be, it doesn't show it great in this picture, but proportionally their tongue is bigger in their mouths than an adult's in its mouth. Their epiglottis, again, has a U shape. It's longer, it's floppy. And then they've got that funnel airway that kind of comes down to the cricoid at the narrowest point. So their thoracic cavity is also, the diaphragm's developing just like all the rest of their muscles. So it's going to need time to develop as well. And they have a very, especially babies, a very compliant chest wall, which means, you know, they're squishier, their ribs are going to have more give to them. In general, everything has more give to it. So they don't have kind of the nice firm chest wall that we have as, you know, we expand out. That compliant chest wall means, you know, they're going to have worse retractions with any work of breathing. It's much harder to break a baby's ribs than it is in adults because it's got that elasticity to it. So gas exchange and transport, again, happens down in that alveolus, that little bulb shape at the end of your airways. And that's, you know, the functional unit of gas exchange. That's where it occurs. The exchange of oxygen and carbon dioxide is just simple diffusion, if you remember chemistry terms and things, but it's just crossing across the membrane. Oxygen comes in, CO2 goes out. You have that whole network of pulmonary capillaries. And in the alveoli themselves, there's two types of pneumocytes, or two types of lung cells. Type 1 is the kind of lining of the alveoli, and that's where gas exchange happens. And then type 2 are little kind of spots on that that are epithelial cells that produce surfactant. So anything, as we go through, if you hear that something damages your type 2 pneumocytes, that's going to affect their surfactant production. Again, these are just principles to think of, but again, compliance is the distinction of how elastic they are, how easily they expand. And you know, you think about it, expansion's a good thing, but if you have too much compliance, it's almost hard to fill those airways up when you really need to, if there's a problem. And then surfactant has an effect on this as well, because if you don't have enough surfactant, it makes it too easy for those alveoli to collapse in on themselves and too hard to open back up. And then resistance is just any obstruction to airflow. And I've got this word that I don't know how to say, Pusey's law, but I'll go over that in a second. But it basically, it deals with the flow of air through a catheter or a tube. But that kind of speaks to the role of the upper airway as we branch down into the lower airways. So this is kind of a picture of like what I was talking about, the diameter of the airway. So an adult starts out big and their mucosal lining is relatively a small part of their airway. So that as you get, this is showing like 1 millimeter of edema. That edema is only going to affect the adult airway a little bit. You know, it's only showing maybe 10% smaller here, but in a normal child's airway, that 1 millimeter of edema is significantly affecting their airway. So that law we talked about, it basically states that the flow of a fluid or including air through a tube varies based on the pressure of the air going through, the diameter of the catheter or tube or the airway, the length of it, and the viscosity of the air. So how long is your tube? How narrow is it? And how turbulent is the airflow? Is it smooth airflow? Is it turbulent for some reason? So that's what that law says. So vascular pressures and resistance, this is going to change as they go from fetal to adult circulation, because if you think about it, a newborn baby, they've got those collapsed lungs, they haven't taken their first breath yet, so their pulmonary vascular resistance is high, like we talked about last week. But as they take their first breath, you're going to see an immediate change in that. But babies also have it's much more gravity dependent on their blood flow. So the lower part, whatever's lowest in their body, is going to have much better blood flow than an adult that can compensate for that without needing gravity so much, or being able, I guess the inverse is adults are able to overcome gravity better than kids are. Ventilation perfusion matching is something I'll talk about more in the next slide, but you want to make sure you're getting the air in the airways, but you also have the blood flow into those spaces as well. And so if that matches up, then you can have better gas exchange. So VQ mismatch, you're going to hear this probably on the test and as you're studying for it, but it's the air to blood ratio. V is ventilation, Q, I'm not sure how they came up with that, but that's perfusion. So ventilation and perfusion. So what's your airflow like? What's your blood flow like into your lungs? And the more that matches, the better your oxygenation and ventilation is going to be. So a normal VQ ratio is 0.8, and this is to changes in gravitational flow and just the way the blood flows, but usually you want it to be 0.8. And if you hear about a VQ mismatch, it's because there's some kind of change in that relationship. Either you have not enough ventilation, not enough airflow, or not enough perfusion. So it can be for either of those things, and you want to figure out what it is and why before you can figure out how to fix it. So an intrapulmonary shunt is just the word you might see for something that's affecting the ventilation, the airflow, the V part of the VQ mismatch. There's a ratio to determine the intrapulmonary shunt. It's called the PF ratio. So that's determining the presence and degree of the shunt. So things that can cause a shunt are like fluid filling the alveoli or some kind of blockage from mucus, something like that. It's a pulmonary shunt. We're talking about airflow here. So the PF ratio is their PaO2 divided by the FiO2. So normal is going to be, usually it's easier to think of 300. This has a very specific number of 286, but in general, think about 300 is normal or above that. If it gets below 200, you're in ARDS, and if it gets below 100, you're in severe ARDS. But the degree to which that is decreased indicates the presence of the shunt, and usually this is reversible. We just need to figure out the cause and fix it so we can restore airflow. But the less this gets, it's basically saying if your PaO2 is 100 on your gas, but you're on 100% oxygen, that's 1, right? FiO2 is up to 1, so it's in points. So that's 100. So that's pretty bad if you're on 100% FiO2 and your PaO2 is only 100. But if you're on 21% air, which is 0.21, and your oxygen sat's 100, it's whatever that math is, which is way better. But the less airflow you have into your lungs, going up on the oxygen has less and less of an effect. So if your VQ mismatch is really big because air is not getting to the alveoli because of either being filled with fluid or some other kind of blockage, then going up on your FiO2, that air's still not getting into the alveoli. So if there's still a big shunt, you're still not getting that air in there. It doesn't matter. Turning up the FiO2 is going to have less and less of a return on your investment, basically. So this is another thing you might see. This is the oxyhemoglobin dissociation curve. And this is something I have a hard time remembering off the top of my head, left shift, right shift. So I'll give you a mnemonic to help. Left is letting go. So it's having a decreased affinity for oxygen. Oh no, sorry, left latches on. Let me go to the next slide so I don't mess it up. Left latches on. So increased affinity for oxygen. So a left shift is going to make oxygen bind to the hemoglobin easier. But what that also does is make it harder for that oxygen to get away from the hemoglobin. So hemoglobin just wants to latch on. So it makes it easier to oxygenate the blood in the first place. But the further that left shift gets, the harder it is for the tissues to actually get oxygen. So even though your SAT might be good, you still might have cellular hypoxia because it's not actually getting to the cells. Fetal hemoglobin has a left shift to start with, and usually by 4 to 6 weeks, that's been all replaced by regular hemoglobin. But for the first 4 to 6 weeks, babies are going to have a natural left shift. But some other things that can affect it is hypothermia, or an increased pH, so alkalosis, a decreased CO2 level, and carbon monoxide. So all of that is going to make a left shift. A right shift wants to release oxygen. So if left is latching onto oxygen, right shift releases oxygen. So the oxygen wants to get away from the hemoglobin. It's going to make it harder to get the oxygen to latch on in the first place inside the lungs. But once it gets to the tissues, it's going to leave out easier. It's going to unload easier from hemoglobin. So some things that cause that is an increased CO2, so a decreased pH, because those are inverse, so acidosis, and hyperthermia. All right. Last set of principles before we start talking about all the problems or the diagnoses is lung volume. So you will see, I noticed a lot of questions that talk about some of these, especially this one, functional residual capacity. But this is just showing a normal lung volume and the different terms for it. So the normal air you're breathing out with each and every breath without much effort is your tidal volume. But if you take a huge breath in, that gets you up to your inspiratory, that adds on your inspiratory reserve volume. And so that whole number is going to be your inspiratory capacity. But that's still leaving the breath out to a normal level. If you were to expel all the breath you can from your lungs, that gets you down to your, that's your reserve volume at the bottom. And so that whole thing, if you went all the way out, all the way in, is your vital lung capacity. There's always going to be a little bit of air left in your lungs because alveoli don't do well without any air at all. They'll collapse in on themselves. Your lungs are going to keep a little bit in reserve just to keep those open a little bit. So you can't forcibly or yourself get all the air out, which is why if you get the wind knocked out of you, it's kind of hard to get that first breath in because re-expanding your lungs is hard to overcome. But one thing you might hear on the test is functional residual capacity. So that's the residual volume, which is what's always left in your lungs, plus that expiratory reserve volume. So what you could get out of your lungs if you gave a forceful exhalation. And where you might see this, what you might see this asked about is either in reference to a ventilator setting, like PEEP. PEEP is going to increase your functional residual capacity because PEEP kind of gets you up to this level. You know, if you think on the ventilator, it's what's kind of holding your lungs open. They could go out more if they wanted to, and then you're adding the tidal volume or the pressure on top of it to make a tidal volume. But PEEP is going to increase your functional residual capacity, and disease states like asthma are normally, you know, at baseline going to increase their functional residual capacity because they start trapping air and more air gets left over at the end of their normal exhalation. So that both those things are examples of things that could increase their FRC. But that is something I saw in some of the practice questions. That's a term they like to use. All right, so now we're going to start going through the different things on the test plan. So first is pulmonary edema. And this is just the movement of fluid into the alveoli. It's edema just like anywhere else in the body. It's fluid, some kind of fluid outside where it should be. So it's either filling up inside the alveoli, and it can also fill up in that interstitial space, kind of between the alveoli capillaries, you know, in that inner space. So you can have, it kind of can come from two different areas. It can either be cardiogenic, which for that, just think it's coming from the blood vessels, or non-cardiogenic, and that's coming from the lungs. So cardiogenic reasons could just be too much IV fluids. You've overloaded them with too many fluid boluses or something like that. Or they're in some kind of renal failure that's causing them to keep up too much volume in their body, and that's going to leak out everywhere, including their lungs. It can also come from ventricular failure, because as that left side fails, fluid backs up into the heart and is going to leak out into the alveoli. And then sepsis, because that also causes leaky vessels. Some non-cardiogenic reasons is going to be mostly ARDS or some other primary lung disease. So this is kind of a picture of just pulmonary edema. So you've got, it's just fluid filling your lungs, basically. It kind of differentiates on between cardiogenic and non-cardiogenic, because if it's non-cardiogenic, it's something like ARDS where there's more happening, right? Your lungs are sick for some reason. So there's going to be white blood cells involved, just that, you know, much more of a inflammatory response. In addition to it, you're probably going to have other problems than just the pulmonary edema. So how does this show up? You can have shortness of breath, you're going to feel air hunger, cyanosis if it gets bad enough, decreased breath sounds, and usually you think of like crackles and wheezes. Pink sputum is something like a trigger word. You know, if you hear pink sputum, you should think pulmonary edema, but that's not going to show up till it's pretty severe. And then to manage this, you're going to want to treat the cause, because this is more of a symptom than it is a primary thing typically. You can give them oxygen to supplement. If they're on a ventilator, you can increase their PEEP PEEP helps pulmonary edema. It helps hold things open to kind of counteract that effect. But usually diuretics are what you're going to look to, assuming their blood pressure can handle it. But if it's especially cardiogenic causes, like heart failure or too much IV fluids, diuretics are going to help. And then inotropes if you need to help your cardiac output to help move that fluid along. All right, next up is pulmonary embolism. We don't see this a lot in kids. It's relatively rare. There are some groups that are at a higher risk, like sickle cell, or if they have some underlying, either already a DVT in some other part of their body or some kind of clotting problem. But it is associated with a high risk, high morbidity and mortality. And it may go underdiagnosed, especially in peds. It's not usually the first thing we think about. So pathophysiology, it always starts with thrombus. You have some pocket of something. The easiest thing to think of is a clot, but it can be a fat embolus if they've had a recent orthopedic surgery, some kind of broken bone that's been fixed in the last week or two. You might see something about that. And that kind of, if they have a week or two after that, a sudden onset of respiratory distress, think fat emboli that went to their lungs. But it could be a septic emboli. If they're septic and, have that inflammatory process throughout their body, they're going to have those septic emboli of like chunks of bacteria and kind of almost pus in their blood, but, things like that. It can be an air embolus, a tumor, or some other injected foreign material. But the size and location, that's going to determine where it occurs in the pulmonary vascular, and how big it is going to determine how bad your symptoms are. So obviously the bigger it is, wherever it occurs is going to occlude the vessel and all of that downstream perfusion. So that's going to cause a VQ mismatch, because then your perfusion is inadequate. You're not getting blood to all the places you need to, which means you're going to see hypoxia from that, depending on how bad that blockage is and how big it is. It can either be a complete obstruction, partial obstruction. Usually the first thing you see it's not usually a drop in their oxygen level, but it's going to be restlessness. You'll probably see a tachypnea, things like that. Oxygenation, hypoxia is usually a late sign unless it's a huge obstruction. And then there is a potential for heart failure, just as we treat it, depending on how big it is. The heart's having to push harder against that obstruction, because if that section of the vasculature is blocked off, that increases the resistance, and it makes it harder for the blood, or for the heart, to push the blood to all the other parts that it can go. So at-risk populations, like I said, sickle cell disease, because once they start that sickling process, it can cause occlusions in all of their small vessels, including their chest, their lungs. So that gets worse from dehydration and just leads to a cycle where they get more and more sickling. If they have nephrotic syndrome, cancers, chemotherapy, anything that makes them hypercoagulable, and vasculitis are all risk. So management, the biggest thing is early recognition and diagnosis. Like I said, it can be underdiagnosed in kids, but you want to start them on some kind of anticoagulation. So immediately you might be starting them on a heparin drip. If it's something that becomes more of a chronic issue, they could transition to some of the injectables. If it's bad enough, they might need thrombolysis or some kind of, surgery to go in and do an embolectomy. And if they're really high risk or have recurrences, they might need one of those IVC, the vena cava filters, to kind of filter out any clots before it gets to their heart. That's just in the lab. In the meantime, cardiac support if they need pressors in the interim until it resolves, antibiotics, and they might need blood cells just because you want to kind of tank them up to increase their oxygen carrying capacity. All right, moving on to respiratory failure. This is a little out of order if you're following the test plan, but it had ARDS in front of respiratory failure and more of a progression. So we'll start with respiratory failure. So this is, a pretty generic term, but it's an inability of the respiratory system to meet the demands of the body for oxygen, or the inability to adequately get rid of CO2. So either you're left with not enough oxygen, not enough CO2, or too much CO2, but it's a failure of the respiratory system. You can have pulmonary causes. So it could be, from the lungs themselves, something is impairing the lung tissue, something's causing tissue damage. something that's making increased airway resistance or some other compromise. But you can also have it from non-pulmonary complications. This could be, respiratory failure because something's happening in their brain that makes them stop breathing, either, seizures or meds or something like that, or pressure that's affecting their drive to breathe. You could have upper airway disorders or CV or hematologic disorders. So you're going to see work of breathing. You're going to see decreased lung volume. You could have obstruction in the upper or lower airways. It really just depends what's causing it. And your first thing is going to want to be to find the cause and fix it. But as their respiratory failure worsens, you could see altered level of consciousness, things like that. So management, again, prevention, trying to catch things before they get too bad. Monitoring, giving them oxygen if they need to, and mechanical ventilation. And I'm not going to go over all the different modes of ventilation. I didn't see really a lot of questions about that specifically in the practice questions I've done. They do like to ask questions, though, about how changing certain settings on the ventilator might affect the patient, or which ventilator setting would you change. But mostly it was like changing PEEP, changing rate, FiO2, or PIP. Peak inspiratory pressure, things like that. But what are some complications associated with intubation and mechanical ventilation? So of course it can further cause atelectasis. As your body responds to a foreign object being put into it, can have a negative reaction. You can have a ventilator-associated pneumonia, decrease in your cardiac output, because adding that mechanical ventilation, you're adding pressure into their lungs, especially PEEP can affect, you're increasing their intrathoracic pressure in general, which is going to, put extra pressure on their heart and make cardiac output worse, especially if it's having trouble already. You get oxygen toxicity, so giving too much of a good thing is going to be bad. Too much oxygen will damage their lungs, especially in babies, but even in adults. And then acute lung injury and barotrauma. So giving too much pressure, too much volume can cause injury to their lungs too. So ARDS, acute respiratory distress syndrome. Sometimes you might see this as PARDS, pediatric acute respiratory distress syndrome. And I've seen some places try to call the A adult, but it stands for acute, and in all the review materials, at least for the pediatric CCRN. But this is the most severe form of lung injury. So their lungs are very sick for some reason. Usually it's going to cause a non-cardiogenic pulmonary edema, like we talked about. Their lungs are so sick that they're filling with fluid. That PF ratio is going to be less than 200. And then they're going to have on the x-ray bilateral pulmonary infiltrate. So x-ray is not going to look good. This is kind of what happens in it. And, part of this was on that slide earlier, but it's an inflammatory response. The body's going to act, even if it's not from an infection, you're still going to get that inflammatory response that sends in neutrophils, and, it releases, mediators that are going to cause more inflammation. There's changes in the alveolar capillary permeability. So the permeability of those capillaries to allow gas exchange is going to be affected. There's going to be decreased compliance, decrease of that functional residual capacity we talked about. So an increased dead space in the lungs. With all this swelling and fluid, the air can't get in as well as it should. So that causes the VQ mismatch, eventually hypoxemia. It's going to damage the lining of that cell. So this is what I was talking about earlier, but these type 1 cells kind of line the alveoli, and you have these type 2 cells that make the surfactant, and it's going to damage both of those. So the lining is what allows for gas exchange. It's not going to be able to do that as well. And it's going to damage the type 2, which makes surfactant, which make it even harder for the lungs to open up as well. So all of that, it kind of creates a vicious cycle. And the goal of treatment is going to be to somehow break that cycle. So this kind of talks through the pathophysiology, but a local or systemic insult activates that systemic stress response. It can be an infection. It can be just a generalized body reaction. You can see ARDS from sepsis or from near drownings, or some kind of toxic inhalation, just something that activates that stress response. Will is asking a question. is the PF ratio under the assumption that they are at a baseline PEEP. I know if we increase the PEEP, they require less FiO2. The PF ratio in general doesn't make assumptions, I guess. You're right, increasing PEEP is going to help with FiO2. Usually, because that helps keep those alveoli, it helps push them open even more, which helps aerate more, which can hopefully help you decrease your FiO2. So if your PF ratio is off, it's showing you that there's some problem with the air getting to all the parts of the lung it needs to, either because of fluid or obstruction or something. So increasing your PEEP should increase that functional residual capacity, which should make that VQ mismatch better, less mismatched, which helps your PF ratio. Does that make sense? Yes, kind of. Okay. So back to ARDS. So you have that stress response, the neutrophils rush to the area, you have inflammation, you have the increased capillary membrane permeability, so they're going to start leaking all over the place. You're going to get pulmonary edema, increase in your vascular resistance, just because everything's kind of swollen, inflamed, and clamped down. It can also lead to bronchoconstriction, which then kind of makes problems on both ends, and pulmonary hypertension. And then you're going to, overall, this bottom part, it reduces that functional residual capacity and decreases the compliance of your lungs. Okay, so management goals. Your main thing, you're going to want to support oxygenation while, looking for the cause of ARDS and managing that. This doesn't happen out of nowhere for no reason, so you're going to want to find out what caused it to happen and try to treat the cause. But in general, I bolded the ones that dealing with ARDS directly. So optimize their oxygen delivery, minimize their oxygen consumption. So these are the patients are going to want to sedate, try to decrease their, O2 demand, make sure they're not feverish. Anything you can do to try to minimize how much oxygen their body needs so that the oxygen they have can go where it needs to go. You want optimal fluid and nutritional support, and then check for any infectious diseases or, like I said, find the cause. These patients are going to be on some kind of ventilation therapy. They're probably going to be intubated. You can use volume control versus pressure control, and this is just going to vary patient to patient. It's going to depend how bad that pulmonary edema is, how bad that compliance is, because you need to get the oxygen in there, but you don't want to damage their lungs. Their lungs are going to be pretty stiff from being so sick, and so you don't want too high of pressures. PEEP, like we just talked about, is going to help to kind of keep that open. And you're going to let them be a little hypercapnic, having the CO2 a little bit higher. The definition of hypercapnia or permissive hypercapnia is allowing a higher CO2 as long as your oxygenation is normal, your pH is still above 7.2, and you have no evidence of cerebral dysfunction. Because CO2 affects the vasculature in the brain too. You don't want to make their brain sicker if that's their problem. But with normal cerebral, with no problem of cerebral function, you can allow a higher CO2. So you might see CO2s of like 50 or so in these patients, in the 50s, maybe as high as the 60s. It just depends. Sometimes you have to pick your battles, and getting their oxygen right is the first goal, and then kind of fixing the ventilation when you can. Some of these patients can go on the oscillator, and sometimes that's what they need because, again, their lungs are so stiff it's hard to get the tidal volume you need from regular ventilation. So you might go on the oscillator, which has those, multiple short breaths. They might need ECMO. They might need nitric to kind of dilate that pulmonary vascular bed to try to fix that problem. Prone positioning can help in these patients, and you might see them on a rotation bed. Another factor of that is help minimizing their O2 consumption, like I said. So first, we want to optimize their oxygen and their output. So they might need, want to make sure they have a normal preload. That might mean fluid boluses. You're going to want to reduce their afterload if that's part of the problem. Support their cardiac output, so they might need to be on pressors, and maintaining an adequate hemoglobin. So you want to make sure you're keeping their hemoglobin as high as it needs to be to give more oxygen carrying capacity in their blood. making sure you decrease their activity with sedation, but also maintaining their comfort. So along with sedation always comes pain control. And I know a lot of times we think of fentanyl as a sedative, but you kind of need both those things. Because being intubated and being this sick is painful. So you want to make sure they have pain control as well. And then normothermia, you really want to avoid fevers in these patients. But you want to avoid, unless there's some special circumstance, hypothermia too, because that causes, the left shift like we talked about, which makes it harder to oxygenate the cells. Going on to optimizing fluid and nutrition. So this is maintaining a normal CVP. Again, making sure they have enough fluid on board. You don't want to overdo it because that can make the pulmonary edema worse, but you do want to make sure they have enough for their cardiac output and for renal function. These patients, if they're this sick, they might go into multi-organ system failure, which can start with renal failure often. So you want to make sure they have enough CVP to have good renal blood flow. Diuretics, on the flip side of that, diuretics is needed to make sure they're not fluid overloaded. Making sure they're going to have increased protein needs because they're hypermetabolic. Their body's working overtime to try to fight whatever it is. So they're going to use up lots of protein, lots of calories. So you're going to want to make sure that their nutrition is good to help their body get better. And then starting enteral nutrition as early as you can and as tolerated, but reintroducing enteral nutrition and getting their gut involved sooner has been shown to have better results. For infectious disease, you're going to want to look for either a nosocomial infection if it happened after they've been intubated for a while, but any kind of infection source you're going to want to look for. So that goes with our normal, surveillance monitoring, but monitor their temp, their white blood cells, using universal precautions, and then gastric decompression. So a lot of these patients, we still kind of do this, but we'll start antacid regimens on them right away or gut protection. But there's some research coming out that shows that too much antacids can be a problem because that acidic environment in the gut kind of helps control for the acid or the bacteria that might be growing in the gut. So taking that acid away, making it more alkalotic, can increase the bacteria growth in the gut, which can then, if they aspirate, can cause more problems in the lungs. So anyway, you do want to kind of, have a sump in, keep their belly decompressed so they're not aspirating and making things worse. Yeah. All right, that's ARDS. Any questions about that one? Okay. All right, acute pulmonary infections. Let's see. So this includes kind of this group of things: pneumonia, croup, epiglottitis, bronchiolitis, and acute tracheitis. So we'll kind of go through each one. So pneumonia. This is an infection of the lungs. Again, another vague term. It can be caused by a virus or a bacteria. Where it comes from kind of varies with age. In our babies and pediatric patients, it's usually a viral cause, whereas adults, you're going to see more bacterial causes. It can, one of the common causes in babies is RSV, if it gets, if it progresses. So the picture of this looks pretty similar, to ARDS. It's just hopefully not as severe. You're not going to see as much of that swelling, not as much of that damage yet. It can progress to an ARDS picture, but you're just going to start off with some kind of, this step one is usually the arrival of some kind of pathogen. So that bacteria or virus gets into your lungs and starts multiplying. So as it multiplies, it's going to cause that inflammatory response, which is going to cause some level of alveolar edema, just not as bad as ARDS. It's going to cause that inflammatory response, kind of, all hands on deck with white blood cells showing up, releasing their things, which can, cycle upon itself to kind of make worse and worse inflammation and swelling. So hopefully, if it's not too bad, the lungs can recover on their own, but a lot of times, especially babies, they're going to need some kind of support. You can get lung consolidation, so kind of like pockets of this just really infesting into the lungs. And overall, any of these damaged areas are going to have, again, reduced compliance, reduced total lung capacity, VQ mismatch, all that. So some risk factors for this. If they have an artificial airway, that's, it's bypassing all of the normal upper airway defense mechanisms, that you have in your nasal passages. to try to filter out bacteria, and giving a direct line into their lungs. So an ET tube or trach is a risk factor if they have any kind of aspiration that can introduce a bacteria or virus, usually bacteria if it's aspiration. Any kind of abnormal airway secretion clearance. So this is something like cystic fibrosis, chronic diseases, if they have chronic lung disease, BPD, and then inadequate nutrition kind of sets their body up for failure to be able to fight it. So what you're going to see with this, usually there's a high fever, sometimes with or without chills. They're usually going to have a cough with chest pain, but the chest pain's more, they can associate it with their lungs, not their heart. You're going to have a lot of times some upper respiratory symptoms as well. Pneumonia is the lungs, but you might also see some of the upper respiratory congestion in addition. And as it gets worse, they're going to have more and more respiratory distress and cyanosis. And in infants, especially since they have that underdeveloped respiratory drive, you can see apnea as well. So to look for this, you're going to do a chest x-ray. You're going to see, all those infiltrates and things building up. They're probably going to have a lot of sputum, or if they have a tracheal secretions. So you're going to want to send off that to the lab to try to find the cause. So cultures for their lungs, also cultures for their blood to look for any kind of systemic bacteremia, either because it's spread to their blood or vice versa. And then if you need to, you might need to do a bronch or a lung biopsy, but that's an extreme case. But for some of our like hemonkers that are susceptible to everything, you might need something like that to really figure out what's causing it if all the normal things aren't working. But for management, first would be prevention, especially if it's a risk factor like an ET tube, trying to make sure we don't give them pneumonia in the first place. But monitoring for worsening respiratory distress, maintaining their oxygenation, ventilation, a lot of the same things we talked about with respiratory failure and ARDS. Look for complications related to the disease process. They're going to have increasing FiO2 requirements, but trying to manage that as well. And looking out again for those complications of mechanical ventilation if they're on a vent. And maintaining hydration is important because these patients, anytime there's an issue with the lungs and you're mucking around with that stuff, they're going to have an increased risk for insensible losses. So they can lose extra fluid through their lungs. So you're going to want to monitor for dehydration. All right, next is acute laryngotracheobronchitis. So that's just a fancy word for croup, though sometimes you'll hear, especially lay people, talk about croup to mean a lot of different things. But in the medical world and for this test, croup is laryngotracheobronchitis. So that's most prevalent between ages 3 months and 3 years, but it can occur outside that range. And if they get it once, they have a tendency to recur and get it again. It can be either viral or bacterial, but usually it's viral. And usually happens in late autumn, early winter. The most common things are going to be RSV, parainfluenza A, and adenovirus. I think most of the ones I've seen have been adenovirus with a couple paraflus, but you can have non-viral croup as well from asthma, foreign body aspiration, something that's irritated that laryngotracheobronchial area. But what happens with this is that that cricoid cartilage, which again, remember in kids is the narrowest part, so the bottom of that funnel, it swells up. It has swelling and secretions that make it harder for the air to get through. And since it's already smaller relatively than adults, to start with, that extra swelling, that extra secretions is really going to affect their ability to breathe. So you're going to see a barking cough is a buzzword. Remember that. If they have a seal-like cough, that's probably croup. They might be a little bit hoarse, but there's not too many voice changes. You're going to hear stridor with inspiration, nasal flaring, tracheal tugging. They're really pulling to try to get the air in, and retractions. And you might see a low-grade fever. It's not usually too high with croup. The definitive diagnosis is an X-ray, and you're going to see this steeple sign on a AP X-ray. So from the front view, you're going to see this narrowing up into a steeple shape. That's really, you can see this barely looks like they have any air getting through that, but that's if you hear steeple sign, it's croup. And if you do a lateral X-ray, you're going to see a normal epiglottis. So to manage this, you can give them racemic epi that's going to kind of vasoconstrict that mucosa in that area, which reduces that edema. You can also do cool humidified oxygen, not warm, but this is why, if you're telling someone to treat this at home before it gets too bad, like taking them out into the night air, something cool but humidified will help get that air in. Heliox, because that's a lighter air than normal air. So like most of what, normal air we breathe is 21% oxygen, but it's mostly nitrogen. So heliox, instead of having that mix, has helium and oxygen. Helium is much lighter than nitrogen, and it's going to result in a less resistant gas. So flowing through that airway, it's going to make it less turbulent, make it easier to get the air in and out. They might need intubation, but that's usually not necessary. But you're going to try to keep them calm, give them, fever medications if they need it, make sure they're well hydrated, well fed. You can use corticosteroids, but apparently that can be controversial and probably doctor dependent. But the main things are going to be racemic epi, maybe heliox. Epiglottitis. So whereas croup is, not that big a deal, to be honest. It's not great, but it's not terrible. Epiglottitis is bad. It's severe, it's life-threatening, it's rapidly progressive. Usually it happens in kids 2 to 6, but it can happen in any age. Actually, a lot of the x-rays that I found online were from adults, probably because it was easier to get an x-ray out of them when they're actively in epiglottitis. But the mortality on this is high. It's 5 to 10%, and that's because it progresses so rapidly. But some of the causes, H flu is a big cause of it. So the incidence of this has decreased a lot since the Hib vaccine was introduced and more widespread. So we've been able to cut down on at least, the number of cases from that one. But you can also get it from beta hemolytic strep, pneumococci. So as it starts out, there's some kind of initial infection that kind of centers on that epiglottis, causes the epiglottis to thicken up, all the folds around it to thicken up, which narrows the airway and makes that gas flow turbulent. And the problem is that with because it progresses so rapidly, especially with stimulation and agitation, it can swell rapidly even more and close off their airway in an emergent situation. So this is going to show up with what's called the 4 Ds and an S. So you're going to see drooling, dysphagia, so they're not going to want to swallow, their throat's going to hurt. Dysphonia, which is a muffled voice. Distress, they're going to be very anxious, restless. They're not going to be happy people. And stridor is a very late sign. Usually you're going to, in getting the history, you're going to see there was a fever with an abrupt onset. And these are the kids you're going to see in a tripod position. So if you hear a question about a tripod position, it's probably epiglottitis. But they're going to be sitting up, they're going to be leaning forward. They're not going to want to swallow, so that drool is going to be coming out of their mouth. And they're going to be very unhappy. So this is what it looks like. This is the one where you need a lateral chest x-ray. And as you can see, looks like an adult. But it's called the thumb sign. So their epiglottis is thick and kind of, it normally is much thinner than that. So the point is that you see a big, thick epiglottis. So for management, the biggest one the most important thing, and probably what you're going to see in reference on the test, is do not touch them. Do not agitate them. Do not do anything. If they don't want you near them, don't go take their blood pressure. Don't go take their temperature. Don't do anything to them until you have all the people that you need to do an emergent intubation. So whether that's the intensivist, the anesthesiologist, you're going to want to keep this kid calm until you're ready to intervene. But this is usually a medical emergency, and they are going to be intubated in some way, but you want to make sure it's in a controlled manner so you don't have to emergently therapeutic neglect. That's right, Will. Leave them alone. Keep them as comfortable as possible, but you're not even going to put oxygen, just don't touch them until everyone's ready to intubate. Once they are intubated, you're going to want to maintain oxygen ventilation. You just need to give their body time to get over it. You can give antibiotics, especially a lot of these are bacterial, but you're going to need to give them plenty of time for it to go away. So monitoring at the same time for pulmonary edema, but keep them well sedated. This is the last kid that you want to accidentally extubate themselves, because depending on where they are in that disease process and how swollen that epiglottis is, introducing that airway is going to make it swell even more, at least initially. So if they get self-extubated, they may be difficult or impossible to intubate without an emergency trach. All right, so moving on to something less scary and that we see a lot more often is bronchiolitis. So this is an acute inflammatory disease of the lower respiratory tract. So, in adults, we talk more about bronchitis. So that's the bigger bronchus airways. But kids usually have more of a problem further down. So those are the bronchioles. So that's why it's called bronchiolitis. So this is the lower respiratory tract, whereas croup and epiglottitis are still in the upper airway. So an upper respiratory infection, this is the lower respiratory. So you're going to have obstruction of those small airways. Again, kids' airways are small and they're relatively small. So, swelling and secretions are really going to obstruct those little airways. Usually it's a virus. So, for our babies, especially RSV is what we see a lot of in the winter time, but you can get it from other things, even from, rhino, flu, anything like that. Any infant can get this, and any infant can be pretty sick in our ICU with it. But if they have any underlying problems like BPD, congenital heart disease, prematurity, CF, any other thing like that, chronic illness is going to put them at even higher risk. So for pathophysiology, just like any other infection, the virus gets in there, it starts replicating itself, causes edema, causes swelling, causes secretion production, which leads to obstruction and atelectasis. So you're going to see hypoxia. Usually these kids are working pretty hard to breathe. They can have issues with their oxygen and their ventilation, so their CO2, respiratory distress, and if it gets bad enough, respiratory failure. So usually when you take a history, they're going to say they had some kind of upper respiratory symptoms or a known exposure of some family member, friend who had a cold. But they're going to show up coughing, sneezing, runny nose, congestion. They're usually going to have a lot of nasal congestion along with it, which makes it even worse. Tachypnea, retractions, they're going to be working pretty hard to breathe and probably pretty irritable. So for management, prevention is the first thing, but once it's already going, they're probably going to need a little bit of O2 if they're, the ones we see in the hospital, at least, they're going to need some O2. They might need some high flow, some kind of positive pressure, CPAP if it gets, bad enough. The worst cases can need mechanical ventilation, but a lot of the majority of ones we see are just going to need some extra O's, some extra flow to overcome those obstructions. Make sure their fluids and nutrition are good, monitor their chest x-rays to make sure it's not progressing to pneumonia, checking ABGs as needed, and then probably some kind of RVP panel to make sure that it's a virus and not a bacteria. And then acute tracheitis, I don't know that I haven't seen any practice questions about this. But overall, it's an infection in the trachea, which is part of the area that's affected by croup. But so it's similar to croup, it just doesn't respond to the same treatment. It doesn't quite look the same. You're not going to see that steeple sign. And a lot of times the cause is bacterial. And, mostly I've seen this in kids who already have a trach or some kind of artificial airway. All right, moving on to air leak syndrome. So air leak, think pneumothorax, the air is leaking out of their lungs into places it shouldn't be. So a pneumothorax is a collection of air in the pleural space. You can have a lot of different reasons for it. It can be post-operatively, holes show up where they shouldn't. You just took out a chest tube and maybe, there's still some kind of communication where air is, able to get in. Mechanical ventilation can cause this because if you, again, are giving them too much pressure in their lungs, it can cause ruptures in the alveoli, which lets air out into the pleural space. Upper airway trauma and thoracic trauma. So if they have trauma to their airways, that can also cause rips, tears, things that can let air out into the pleural space or even the mediastinal space. So pathophysiology, it's going to be, again, the size of it is going to determine how bad it gets. But these, depending on where the air leak is coming from, it has the possibility to get much worse, much more quickly. So you might see as the size of it increases, it's going to increase the pressure in the lungs, and it's going to So it's going to put pressure on the lungs themselves and the heart. So you can see decreased cardiac output, a loss of vital capacity. They're not able to take as big a breath. Their lungs can't expand because it's, there's that air pressing against them. And you're going to see that intrapulmonary shunting. So air can't get into. So you'll see an increased heart rate, increased respiratory rate. They're going to start working pretty hard to breathe. You can hear a decreased intensity or a change in the pitch of their breath sounds. And if it gets bad enough, even absent breath sounds, depending on how bad it's compressing that lung. If you're on a ventilator, you might see a question about a sudden increase in their peak inspiratory pressure, and that's an indication of a pneumothorax or a new pneumothorax. Eventually, you'll see their SATs start to decrease cardiac function, and leading to cardiorespiratory collapse. So on a chest X-ray, you're not going to see those normal lung markings. You might see a nice, dark, looks like clear lung, but you're not going to see the normal, airways and vasculature of the lung because there's no lung there. It's getting squished over. So it's a uniformly translucent area, no lung markings. So that free pleural air accumulates. And sometimes, depending on how bad this is, it could just be a sliver along the side of their chest, all the way, to a tension pneumothorax where it's taking up almost that entire side. You might also see sub-Q air, depending on where the air is coming from. If it's coming from somewhere outside the body, like from a puncture or an old chest tube site, you might see sub-Q air that collects as well. So a tension pneumothorax, this is a medical emergency. This is where it's progressed to the point where there's a total shift. That whole side is filled with air. It's pushing that lung over. It's pushing the heart over. It's gonna, it needs to be addressed right away. And it looks like this. So this is where the air is either coming in from the outside, possibly coming out from the lungs, but it's accumulating and coming in rapidly enough that it's compressing the whole side over. So you can see this with a sucking chest wound, even though you can get it from other things like if I have pressures on the ventilator. You're going to see that flail chest movement, which is just, paradoxical. One side goes in when it should go out. Severe respiratory distress, increased work of breathing. Oh, I didn't put the treatment. What they're probably going to ask you is the treatment, or I think I have it on a later slide. No, maybe I don't. A needle thoracentesis is the emergent care for this. So if you have a question that shows, any of these kind of symptoms, tracheal shift, lack of breath sounds on one side, things like that, the first thing you're going to do is get ready for a needle thoracentesis. Again, you can see this from a tracheobronchial injury, which, some kind of injury in those big airways that lets air leak out. And that is also going to have sub-Q emphysema, dyspnea, sternal tenderness, because that trauma has happened somewhere in the center here, and they could also be coughing up blood. So management is going to be rapid recognition, chest tube if it's not too bad, but if it's a tension pneumothorax, needle thoracentesis. There's a type called an open pneumothorax, which kind of is allowing air in and out. So positive pressure ventilation with that is just going to help expand the lungs while that communication heals itself up. And then supportive care and pain management, especially if they have a chest tube, that is painful. So you want to make sure their pain's well controlled. All right, apnea of prematurity, as promised. This isn't something that I personally have a lot of experience with, though it happens. So we don't see it a lot, but we do see some of the newborn babies, usually for ECMO evals or something like that, or even, the little ones that come in that are full term shortly after birth. So apnea of prematurity is traditionally seen, again, in premature infants. It usually resolves around its own around 44 weeks of gestation. So if they were born, say, at 36 weeks, then 8 weeks of life is around when they should resolve it. But that's how that math works. So it's a condition where they stop breathing for 15 to 20 seconds, usually during sleep, sometimes associated with bradycardia and cyanosis if it's bad enough. And it's because their central nervous system is not developed well enough. That drive to breathe inside their brain is not good enough yet. So management, IV or oral caffeine. I remember the first time I floated to the NICU and the NICU nurse asked me for a witness on her caffeine bolus. I was like, oh yeah, I could use a caffeine bolus too. She wasn't talking about her, she was talking about her baby. And I had never heard of it at that point in my 1-year nursing career. So, but IV or oral caffeine is going to be, your maintenance treatment to kind of stimulate their brain centers to breathe. But you also want to prevention, so making sure they're normothermic. If these babies get too warm, it makes them too comfy, and apparently they don't breathe. So make sure they're not too warm, normothermia. You minimize stimulation and noxious stimulation during sleep, so kind of giving them a nice restful environment. And then during active episodes, like if they've gone apneic, the first thing is tactile stimulation. So, think of the typical CPR, like baby, are you okay? Like give them a little rub, tactile stimulation. If that doesn't help, you can go on to bag mask ventilation, suctioning, making sure they're positioned well and that they don't have some kind of obstructive apnea that's adding on to the apnea of prematurity. And then if it's bad enough for some of these babies, they might need either nasal IMV or CPAP, so some kind of positive pressure to stimulate their breathing. All right, aspiration. So I kind of think of this as like two separate things, but so you can either have a foreign body aspiration, so think of like an object, or aspiration pneumonia. So that's more of like a liquid thing. It can be food particles, but that has more of the chemicals in it, associated with gastric fluid, that can be more of a problem. So I kind of separate those in my head. So foreign body aspiration, obviously how severe it is going to be determined by what it is that they aspirated and where it went. And how big it is going to determine how much obstruction there is. Infants and toddlers, so as soon as they start getting that pincer grasp and can pick things up, put it in their mouth, and then accidentally inhale it, that's going to be your riskier group. So this can be inorganic, so just, coins or teeth, or what are some other things we've seen? All, up to and including, charm bracelets. Watch out for like necklaces that have little charms on it and they're chewing on them and then bite it off and inhale it. But it can also be food matter. Button batteries, those are the worst. Because that has the chemicals of the battery itself that can then eat away at the lining of their airways. But I've seen plenty of food matter ones too: carrots, grapes, apples, popcorn kernels. My first brain death case was a little girl who choked on a piece of apple. So it can be anything. So clinical manifestations, usually you're going to see it in the right bronchus versus the left, just because it's less angled, so it's easier for it to shoot down that way. But again, depending on the size, is depending on where it's going to get stuck and your symptoms. So if it gets stuck higher up, you're going to have that cough and stridor. But if it's further down, you might hear wheezing, also probably coughing though. So to manage this, you're going to want to relieve their respiratory distress, try to calm them down, minimize stimulation, look for changes in their status. So as to make sure they're not getting worse. They can do a bronch to go in and pull it out, hopefully, but just watching for respiratory distress. Sometimes they cough it out themselves eventually. It just depends how far down it is. And then prevention, obviously keeping little things away from kids and watching them while they eat. So aspiration pneumonia, like I said, in my head, this is different because it's, you're aspirating it's a pneumonia caused by aspirating something. Usually we think of it as from gastric contents. They throw up and then inhale either during a seizure or some kind of other episode. But it can be from kids with swallowing issues, impaired consciousness. They're just trying to swallow and they don't have a good swallow mechanism and they inhale from that. You can also get it from toxins or you can inhale a toxin. I've seen kids that accidentally tried to eat lighter fluid because it was in a Gatorade bottle for some dumb reason.
And like tiki torch fluid is sweet.
Tiki torch fluid. We had a kid on ECMO a couple years ago because he went to drink tiki torch fluid, which is apparently a little bit sweet, and aspirated it because all of a sudden your body's like, what is this? You start coughing inhale that in. But usually if it's an aspiration pneumonia, it's, it has some of that it can lead to a chemical pneumonitis, because if it's gastric acids or toxins, you have something that can eat away at the lining of your airways, in addition to all the other inflammatory responses that happen. So it damages your mucosal surface, leads to alveolar damage, impacts your surfactant and everything. So it can result in pulmonary hemorrhage. Again, depending on how much it's eating away, it can get to the blood vessels and cause hemorrhaging. Obviously, tissue death, pulmonary edema is probably the least worst thing it causes, but you're usually going to see that. And usually symptoms occur within 2 hours, with the exception of food, which I think is sooner. You're going to see that right away, maybe. Well, I can't remember off the top of my head what she said, but that makes sense in my head. Okay, going on to some of the more chronic conditions. So BPD, bronchopulmonary dysplasia. We see a lot of this in the PICU, some of our chronic kids or NICU graduates, but it's some kind of unresolved chronic lung disease of infancy. Usually it's from a prolonged period of mechanical ventilation that cause, some degree of lung damage. The technical definition is an oxygen dependency at 1 month postnatal age. So if they still have an oxygen requirement at 1 month after birth, or after they were due, postnatal age, is that when they were due to be born? I don't know. Either way, it's oxygen dependency after 1 month of postnatal age. So this can be from meconium aspiration, pulmonary hemorrhage, some kind of neonatal pneumonia, or CHF. Sometimes the primary cause isn't clear, but usually they've had some kind of prolonged mechanical ventilation that has caused either the pressures themselves or high oxygen levels that were needed cause some degree of lung damage, and they have a lingering oxygen dependency. And sometimes they just need oxygen. Sometimes they also need some pressure, positive pressure as well. So this is kind of what it looks like. So there's going to be a fewer number of alveoli. Like I said, when a baby's first born, they have all those branches in place, but they don't have all the alveoli. Those grow and multiply as they age. So these babies are going to have fewer alveoli, and they're going to have thicker walls. They're not going to be as compliant. They're not going to want to open up as easy. It makes it, in general, just harder for them to breathe. So what are some risk factors? So prolonged intubation, especially if they were a preemie needing lots of mechanical ventilation in the neonatal period. If they had respiratory distress as a little baby, a birth weight of less than 1,500 grams. For some reason, male and Caucasian are at a higher risk for this as well. And it's associated with higher levels. I'm going to mute you, Anna.
Oh, sorry.
That's okay. And it's, again, associated with the use of high levels of oxygen over an extended period of time. If they had prolonged intubation, chronic inflammation, overhydration, lungs don't like to be wet in general. So if they had that for a long period of time, that can cause it. All right, so pathophysiology. So you're going to see increased airway resistance because those are thicker walls that also have decreased compliance. They're not going to want to stretch like they should. And that's just a result of like long-term atelectasis, long-term overdistension, all of those things that you associate with like being on a ventilator a long time as a baby when their lungs are trying to develop. And we had to do all these things to intervene, but it causes lasting, long-term damage. So physically, you're going to see rapid shallow respirations. They're trying to compensate for that lack of ability to stretch out with adding their minute, increasing their minute ventilation. So basically taking more breaths, just like a baby compensates its cardiac output with an increased heart rate. These babies compensate their minute ventilation by increasing their respiratory rate, but they're going to be more rapid and shallow breaths. They can get respiratory fatigue if it gets bad enough, and you can see apneas and bradycardias from that. Can cause bronchospasm. You can see bronchospasms and atelectasis, and if it goes on long enough, it can cause right-sided heart failure. So these tissues are thicker and harder for the blood to get through, which causes a bit of pulmonary hypertension, which backs up and causes right heart failure. And the term, I did see this term on the practice question, so I'll make sure in case you don't know it. It's called cor pulmonale. If they have heart failure that is as a result of lung problems or lung failure, it's called cor pulmonale. All right, so again, tachypnea, rapid shallow respirations. As this goes on long enough, their chest kind of develops into this barrel shape to kind of compensate. You're going to see chronic hypoxemia and hypercarbia. So these are the kids that come in with like a compensated respiratory acidosis. They're used to having a CO2 level that's higher, so they've compensated, their body has compensated for that, and that's like their normal. These are the ones that kind of sound like a washing machine when you listen to them. So you can hear crackles, wheezes, all the things. They're not very tolerant to fluid disturbances. So if they get too dry or especially too wet, they don't like too much fluid on their lungs. Again, they're at risk for right ventricular failure to thrive because they're working so hard to breathe. Sometimes it's hard to eat or it's hard to get enough calories to grow like they should. And they can have BPD spells. These aren't quite a big a buzzword as like TET spells, but it's just bronchospasms from irritability, agitation that can lead to cyanosis. So some diagnostic findings, again, on your ABG, this is where you're going to see hypoxemia and hypercarbia, but it's going to be compensated. So it's gone on long enough that they have that renal compensation. They've been retaining bicarb to kind of make up for that. So you might not, their pH may or may not be acidotic. It might be a little towards the acidotic end, towards the 7.35, but you might not actually see an acidosis. You might just see the increased CO2. Their EKG is probably going to start, the longer this goes on, to show right ventricular hypertrophy. And I'm not good enough to like spot myself when I look at waves, except, you're going to see these bigger T waves and things like that. And depending on the lead and the direction which lead it's coming from shows you whether it's left or right ventricular hypertrophy. So get a cardiology consult, get an EKG. And then your chest x-ray, this is where you're going to see what the term is ground glass appearance, scattered patchy infiltrates, areas of hyperinflation, and a ground glass appearance. And that's kind of what this looks like. It just looks kind of yucky all the time. But that's why these kids are at even higher risk when they get a virus for doing even worse. So management, you're going to want to maintain their oxygen ventilation. Again, they have some kind of O2 requirement, so they're going to be on some kind of supplemental O2. But they may or may not have a trach. It just depends how bad it is. Sometimes they just need the cannula, but sometimes they might need a trach and some kind of long-term positive pressure ventilation. You're going to let them be a little higher on their CO2s because, again, that's what they're used to. And then just treating their residual lung disease. So they're probably going to be on long-term bronchodilators, Atrovent. They're going to have probably a regimen of respiratory treatments. And diuretic therapy to keep them drier, on the drier side, because their lungs are going to be prone to pulmonary edema. And then promoting their growth and development with nutrition, increased calories, and a lot of times they have some associated GERD, so treating that as well. And then as they get worse, or especially if they're in the hospital for something active, monitoring for respiratory failure, and then getting ready for discharge planning. So these are the kids that are going to need more attention as you get ready for discharge. They're going to need some kind of home care. They're going to need, it can be from their parents, but they're going to need things at home. They're going to need supplemental oxygen and the medicines for their respiratory treatments, and teaching the family those skills of how to do those things. All right. Congenital diaphragmatic hernia. This is one of my favorites for some reason, though it usually doesn't end up well for the babies that have it, but it's interesting. So usually this happens with full-term infants. It's a herniation of those abdominal contents. So let me go to the picture. Somehow the diaphragm doesn't fully develop like it should. A lot of times it happens on the left because, that's kind of where the esophagus is going through the diaphragm. There's already kind of an opening there. So it can be just an enlargement of that opening where that didn't develop as tightly as it should, or just an underdevelopment in any part of the diaphragm that lets those abdominal contents up and through. So usually at the very least, you're going to see small intestines in the pleural space. You can also see the stomach, if it's bad enough, parts of the liver or spleen. And usually that's going to then push the heart over to the right I can't do this. And it's going to affect the growth and development of the lungs. So depending on how severe this is, those lungs may not have had much of a chance at all to develop, especially on the affected side. But even because everything's getting pushed over, even the unaffected side, that lung doesn't have a chance to develop like it should either. And then you're going to see right to left shunting in their heart because those lungs didn't develop, it increases that vascular pressure, which is going to push the blood to the left. So this is just kind of another picture of it, but it just shows how that affected side is going to have a very small lung, very hypoplastic. The other lung is also small. The heart's pushed over. Everything's higher pressure, and you've got things up in the places they shouldn't be. Okay, so what are you going to see with this? You're going to see, again, pulmonary hypoplasia. Your lungs don't develop like they should. There's an overall decrease in the number and size of those airways, a decrease in their total lung volume because their lungs aren't as big as they should be. So then it's going to have a decrease in type 2 pneumocytes, which again is their surfactant. They're not going to be able to produce surfactant like they should. Ipsilateral, so same side lung, the affected side lung is going to have decreased compliance, increased resistance, which is increased resistance to airflow, to expansion, but also increased resistance to blood flow. So that causes pulmonary hypertension. Usually these kids have pretty severe, even after repair, pretty severe pulmonary hypertension. And they could have other issues too. They can have some cardiac issues as well. This is a failure to develop somewhere in utero, so they could have other developmental issues that happen in utero as well. So you're going to want to look, do a full probably genetic workup for other genetic metabolic factors too. But sometimes it can just happen on its own for no good reason. So clinical manifestations, these babies, depending on the severity, are going to be very sick. They're probably going to need to be intubated shortly after birth, but you're going to see tachypnea, retractions. That affected side is going to have, probably maybe absent breath sounds, definitely decrease depending on how much abdominal contents are inside the pleural space. And the point of maximal impulse shift. So basically where you expect to hear their heart sounds is probably going to be different because the heart's moved over as well. Their chest diameter might be bigger than you would expect because as they've grown in utero, their chest cavity had to get bigger to accommodate all those extra things inside it. And along with that, a scaphoid abdomen. So instead of like a nice little Buddha belly baby with a little, pudgy abdomen, it's going to be sunken in because all their abdominal contents are up in the wrong place. So they have a sunken belly. Pulmonary hypertension, cyanosis, and then their chest x-ray is going to look, this is a bad version of it, but something like this. So you can see these are dilated gas-filled loops of bowel inside the pleural space. And if you kind of look at some of these structures of the lines that have been put in, you can see there's an ET tube here that's shifted way over because again, everything's pushed over. And this is what looks like their some kind of sump or feeding tube that was placed. And you can see how it goes all the way over. And this one does end up down here because it looks like mostly this is intestines. But sometimes you'll see it come down and then cross back up into the space, depending on where the stomach is in this situation. So these kids need surgical intervention. They need to have, even if it's not that bad, you're going to want to put their abdominal contents back in their abdomen and patch up that diaphragm to make it so they can't get back up. So preoperatively, you're going to want to do the best you can to oxygenate and ventilate them. Again, they're probably going to be intubated on a ventilator. They might need ECMO. These are the babies we see a lot that come over as an ECMO eval from Parkland, but not all of them will need ECMO. But they might need nitric because, again, they're going to have that pulmonary hypertension. So some nitric to kind of vasodilate that vascular bed. And then positioning is semi-Fowlers. You want to kind of prop them up a little bit to let the abdominal contents have as least pressure as possible on the lungs. And then as much as possible, kind of keep everything in the box as far as their acidosis, their hypoxia, keep their blood pressure up into the normal levels to make sure they're adequately perfused, and then nutrition and support until they can get repaired. So operatively, they can either go in through the abdomen or the chest. It just depends what's going on. The surgical repair, they are going to remove, put things back where they should be, and then again put a patch on the diaphragm to kind of cover up that hole. They have, I was reading there have been a lot of advancements in fetal surgery, so surgery even before the baby's born. So this one approach is to put a scope in, through the abdominal wall into the uterus, and it kind of goes through the baby's mouth into their trachea. They kind of blow up a little balloon in there, because normally as a baby develops, amniotic fluid is going in and out of the lungs. And as the lungs develop, more and more fluid accumulates. Usually it can come out the trachea. So if they blow up this balloon, it keeps that fluid in there, more and more fluid collects, which hopefully that extra pressure helps let the lungs have enough pressure to fight against the pressure of the abdominal content. So that was kind of interesting. You probably won't see a question on that though. So postoperatively, again, same things. Make sure the oxygen ventilation is good. Unfortunately, these kids, depending on how severe it was beforehand, can still be very sick afterwards. Again, their lungs did not get a chance to develop, and so it takes a long time to kind of slowly re-expand and let those lungs grow and develop like they should. So these kids have a long course if they survive. You're going to have a chest tube on that affected side. So if they took the contents out of the left, you're going to have a left side chest tube, but it might just be to water seal or very low suction, because what you don't want is to have so much suction, and for that, especially if you're giving them positive pressure, you don't want that teeny tiny lung to all of a sudden expand out, because it's going to make it rupture. So chest tube on that side. Positioning, you're usually, I've seen questions about this, but position them the affected side down. So if it was on the left, put the left side down, because their that unaffected side, that's their good lung. Essentially, that's their only lung, especially immediately post-op. You want to give that lung as good a chance as it has to expand. So good side up, bad side down. And again, a highly reactive pulmonary bed. These kids are going to have pulmonary hypertension. So make sure they don't get acidotic. That's going to make it worse. Make sure they have good perfusion, nutrition. Family's going to need a lot of support, and again, pain management, because post-op anything. All right, next one, tracheoesophageal fistula. This is another kind of interesting one, fun one to look at. It's some kind of, error in development of all that midline area. So somewhere it's usually just the esophagus, but it can be the trachea as well that has some problem developing. And with or without a connection between the esophagus and the trachea. So 80 or almost 90% of the ones you'll see is going to be this one right here in the middle, esophageal atresia with a distal fistula. So their esophagus comes down, and instead of going straight down to connect to their stomach, it just stops. It's a blind pouch, they say. And then the esophagus coming up from the stomach swings over and attaches to the trachea. So you have this connection between your stomach and your lungs, and no connection between your mouth and your stomach, unless you go through the trachea, which you don't want to do. Food does not want to go through tracheas. So the problems you're going to see with the very first feeding, and it can come with these other variations, but these are much less common. You can have a proximal fistula, so the esophagus comes down and dumps right into the trachea, which is bad. You can have a double fistula where you have an upper and lower fistula, or you can just have atresia by itself. That happens apparently in 8% of the cases where it just doesn't develop, but there's no actual connection to the trachea. And you can just have a fistula with an intact esophagus. So the esophagus goes all the way down to the stomach, but there's some kind of connection between that. And this is kind of almost like a silent, killer, because at first they may be eating and feeding well, but any reflux, is going to go straight back up into their lungs. So that's not good. So this is a congenital defect. Again, that whole area develops in the 4th week of gestation. So it happens very early on. And what you will see with that is, in a normal baby, they're going to swallow amniotic fluid. It goes into through their system, and they pee it out. These babies can't swallow because the esophagus doesn't go anywhere. So you're going to see polyhydramnios. They can't swallow that amniotic fluid, so it's going to build up. inside the uterus. But with their very first feeding, if they have that esophageal atresia, they have tons of oral secretions, regurgitation of saliva, severe coughing, respiratory distress, because that milk can't go anywhere. It kind of gets stuck in that pouch, and they're just gonna try to get it right back up. So along with this, you can see associated anomalies, other midline defects. So anything that's developing in that mid area can also be affected: cardiac, GI, musculoskeletal. And in fact, a lot of the kids we see this with have what's called VACTERL syndrome, which I can't remember all the letters, but the TE is tracheoesophageal problems. And then there's renal issues, limb abnormalities, cardiac issues, things like imperforate anus. I can't remember the V. Remember the V? VSD maybe. So it's a whole collection. It's a syndrome with a whole collection of deformities. So for management, preoperatively, you're going to want to maintain oxygen inhalation. These kids are going to be NPO and, in fact, no vertebral. Thank you, Lindsay. Vertebral. So some kind of vertebral abnormalities. It's fine. So pre-op, they're going to be NPO and not even any pacifiers, because pacifiers are going to increase saliva production, and you don't want anything that they're going to try to be swallowing down. So positioning them prone so those oral secretions can come out of their mouth. Try to decompress that area as much. So you might see a very short sump to kind of decompress that little line pouch, and then just maintaining oxygen ventilation. They're going to be on fluids, TPN, some kind of parenteral nutrition until you can correct them, and then checking for those other abnormalities. So depending on where it is, where the fistulas are, that most common one can just be a primary repair where they, take away the fistula and reconnect. But it depending on how, some of the other weird ones, they might need to have a staged repair with multiple surgeries. All right, post-op, this is kind of standard post-op care, gastric decompression. You're gonna let that all heal up before you start. They're still gonna be on IV fluids and TPN for a while till it gets healed up, and then some kind of feeding tube can, allow for enteral feeding. Pain management, infection prevention, all that good stuff. All right, tracheomalacia. So this, just think floppy airway. This is a floppiness, weakness of their trachea walls. So they're going to want to collapse in on themselves. It's usually the distal third of the trachea, so as you're getting down further towards the carina. But it can cause tracheal collapse, especially when they're coughing, especially when they're crying, especially when they're trying to feed. So you're going to hear stridor, because again, trachea is upper airway. Stridor, think upper airway. It can be congenital, but it can also be caused from other things like a vascular ring. So I saw there was a practice question. I can't remember if I included it in today's practice, but asked some question about a kid with a vascular ring and how you would position them. And I'll get to how you would position them. But any other kind of compression, some kind of thing from that, and prolonged mechanical ventilation can kind of affect the development of that trachea. So again, you're going to hear a stridor that's worse when they're agitated, a cough, and sometimes inspiratory retractions as they're trying to overcome that resistance in their airway. So management, prone positioning is what you're going to want to do with that, putting them on their belly. It just allows, for that trachea to not collapse like it should. Elevating the head of the bed to have less gastroesophageal reflux. They can usually get better. Usually these kids can kind of grow out of it, but sometimes because as they grow, the cartilage becomes more firm, the trachea itself gets bigger, so a little bit of collapse isn't as big a deal. So a lot of times they grow out of it. But if not, you can do some repairs, aortopexy, stent placement, and removal of that vascular ring that's causing the collapse of the trachea. And then tracheal stenosis or I think I forgot, this is a typo. This is tracheal stenosis, not tracheomalacia, but this is just a narrowing. Stenosis, like in any other part of the body, is a narrowing of the trachea. So sometimes it's just happens out of nowhere, and sometimes it's from trauma that causes, scar tissue and things that kind of narrows the trachea. But again, you're going to see stridor, dyspnea. You can use a bronchoscope to dilate it, but usually that's a temporary effect. So sometimes, depending on if it is scar tissue, they might need resection and reconstruction. All right, pulmonary hypertension. So we can see this from a lot of different causes. Like I said, congenital diaphragmatic hernia. Those kids are going to have pulmonary hypertension. You can also have, primary pulmonary hypertension in the newborn, or persistent pulmonary hypertension in the newborn. So just, a newborn that has pulmonary hypertension for no other discernible reason. That's a primary source. But it can be secondary from a lot of other things. So meconium aspiration can cause this. Some temporary changes like hypoxemia is a big, vasoconstrictor. Acidemia is a vasoconstrictor. So anything that's happening in their body that is causing that can cause, a secondary pulmonary hypertension. So if they have asphyxia at birth, again, that's hypoxia, that's going to vasoconstrict them from birth. Sepsis, pneumonia, hypothermia, any of that. It can also be caused by a hypertrophy of their distal vascular pulmonary smooth muscles. So this is usually in response to some kind of chronic hypoxia. So that can come in utero from fetal or placental insufficiency, or some kind of prenatal closure of the ductus arteriosus. So that ductus arteriosus, which is supposed to stay open until a day or two after birth, for some reason closes prenatally, which increases their pulmonary blood flow and causes those vessels to get some hypertrophy because they're not expecting that soon. You can also get it from hypoplastic alveoli. So this is like congenital heart disease. Those alveoli don't get a chance to develop like they should, and the vessels around them, and so it's caused from that. And then you can get it from a functional obstruction to pulmonary blood flow. So that think thick blood, like polycythemia or hyperfibrinogenemia. But a diagnosis of this is a mean pulmonary arterial pressure of more than 25 at rest or more than 30 during exercise. So again, you can classify it in multiple different ways. Just primary pulmonary hypertension, you can have it along with left heart disease. And because if you have left heart disease, blood's backing up, which can cause the pulmonary hypertension. It could be associated with respiratory disorders and hypoxemia, or due to chronic thrombotic and embolic diseases. Okay, so what happens with this? Well, your pulmonary artery pressure goes up, which causes some left to right shunting. It's harder for the right side of the heart to push into the lung, so instead it shoots off to the left side of the heart. And then from that's blue blood going to the heart. You can have, systemic hypoxemia, especially if you have acidosis. So the worse the hypoxia is and the acidosis inside your lungs, the worse the constriction gets, which causes further pulmonary hypertension and further increased pressure. So it can become a vicious cycle that you need to interrupt. It varies with how severe it is. Some of these kids can be very severe, and how it looks or how it presents depends on how much of that shunting there is inside the heart. So you can have pretty wide and rapid swings in their O2 sats and their PaO2. Usually their preductal PaO2 is going to be higher than their postductal PaO2. And you're going to see the cyanosis and hypoxia from that. So to manage this, your main goal of management, and if you can't remember all the things, like just remember you want to dilate those pulmonary arteries, dilate that pulmonary vascular bed to open it up and increase their PaO2. So hyperoxygenation with these kids before you do anything to them, you're usually going to pre-oxygenate them, hyperventilate them to try to get that CO2 down, because higher CO2 is going to cause acidosis. But be careful with that you're not going over. As with anything, don't go overboard. IV vasodilator. So this is something like Flolan or Remodulin that are continuous infusions that you can start them on, but those and they work systemically, but they vasodilate, including the pulmonary vascular bed. High frequency oscillation for these kids, inhaled nitric oxide, which again is a direct vasodilator, but you can't go home on nitric and it's super expensive. So it's only used in the hospital, and you have to watch out for methemoglobinemia. I don't know if they'll ask about that, but you want to check methemoglobin levels regularly. You can use ECMO for these kids if it's bad enough until you can get it under control, or if it's a secondary cause, get that taken care of. In general, you want to keep them happy, decrease their stimuli, help maximize their cardiac output with vasopressors if needed, making sure they have enough intravascular volume, family support, all that. And just a word about constrictors versus dilators. So, I've kind of been saying this, but just so we say it directly, like these are the things on the left that are vasoconstrictors. So hypoxia, acidosis, hypothermia, hyperinflation, and agitation. All those are going to clamp those vessels down. And then vasodilators are going to be oxygen, alkalosis, normothermia, sedation, nitric, calcium channel blockers, and prostacyclins. All right. Status asthmaticus. So we do see a lot of these kids come in, at least to the PICU. But this is a severe asthma episode that's refractory to first-line management. So this is the kid that starts going into an asthma episode. They're not responding to their normal inhalers and have to come in emergently to the ER. So this is a medical emergency, and it can progress to, rapidly to respiratory failure if you don't intervene. So it's characterized by, these four things all working together: airway inflammation, mucosal edema, so swelling of the mucosal lining around the airways. The airways get plugged up, and bronchospasm. So all of that together, inflammation, edema is going to make them narrow, bronchospasms constrict them even further, and then you can have secretions that cause plugging. This is just the pathophysiology. You have some kind of stimulus that causes the bronchioles to respond. And, asthma in general, they have an overreactive pulmonary airway system. So they're going to overreact to any stimulus and then start to release those mediators that cause the swelling and inflammation and things like that. So this is going to result in a VQ mismatch because, again, those airways are constricting off. Air can't get into where it should. So there's physiologic dead space. Their respiratory muscles are going to try very hard to force exhalation. These are kind of kids you see like really having to try to push out, prolonged expiration to push that airway out because the air is getting trapped inside. So you're going to see increased respiratory rate, increased respiratory effort. If all of a sudden you see these kids get their respiratory rate gets much better and their effort gets much better, it's probably a bad thing. They're tiring out. They're not able to compensate and overcome that obstruction. So you can see decreased cardiac output because again, they're air trapping. That obstruction makes it hard for the air to get in, but it also makes it hard for the air to get out. So they're air trapping. You're going to see hyperinflated lungs on their X-ray. And so that extra pressure is going to affect their cardiac output. Altered level of consciousness. This is how alert they are. And you're also these are the kids you're going to ask them questions and see how many words they can say in a row without taking a breath. If they can only say a few words in a row and then an hour later only one, and then, a little bit later they can't even speak to you because they're so out of breath, that's bad and it's getting much worse. So you're going to see, along with, that hypoxia, their central nervous system is going to start to be affected. So along with the altered level of consciousness, the first thing you might see is restlessness. So they're just going to be restless, followed by lethargy and followed by confusion. And all of those are bad signs. So diagnostic chest X-ray is, again, going to show hyperinflated lungs. You're going to check everything else, RVP to check for sources, CBC, ABG. But the main thing is to restore airway patency. So we want to reverse that collection of processes. So reverse the bronchospasm, try to control the inflammation and decrease secretions. And I have done here plus or minus intubation. This is something you want to avoid as long as possible. If you are intubating an asthmatic kid, it's bad. It's really bad. It doesn't, it has the potential to go very badly because their bodies are actually doing a lot of hard work keeping those, getting that air in and out. And if you have to take over that, and sometimes you do, but if you have to take that over, it's very hard to ventilate these kids. It's very hard to oxygenate them. So if you ever hear that we're intubating a status asthmaticus kid, be scared. So you want to avoid that as long as possible. But if they can't say words and if they're lethargic and if they've stopped working hard to breathe and you hear absent breath sounds, that's, you want to intubate them right away. And then Oh yeah, I just made a note to say you're going to use probably a volume control versus a pressure control because you want to avoid any additional overdistension because they're already going to be overextended in their capillaries. So pharmacology, inhaled beta-2 agonists. So this is like albuterol, but it can also be inhaled terbutaline or epinephrine. We see those less frequently. We'll use IV terbutaline a lot, but usually what this is just a continuous albuterol. So these are kids that start with, back-to-back treatments in the ER, and then we have to put them on 5 milligrams up to 10 milligrams an hour, 20 milligrams an hour, and just keep going up on the dose. And then if that's still not working well enough, anticholinergics. So this is like Atrovent. So this helps with bronchodilation because it blocks the parasympathetic receptors and decreases the vagal tone of the airway. And then corticosteroids help stop that inflammatory response. So that helps with swelling and secretions. And then systemic beta-2 agonists, and that's like IV terbutaline. So we'll put these, give them maybe a bolus of terbutaline and put them on a drip. Other things can include magnesium sulfate. That's it's a smooth muscle relaxer, so it's going to cause smooth muscle relaxation everywhere. So you can have diarrhea with it. You can see a drop in their blood pressure, but along with that, it's going to bronchodilate the smooth muscles of their airways as well. Mucolytics, antibiotics. Sometimes you'll see them, it depends on the doctor. I don't see it as much anymore, but like an aminophylline drip or theophylline. And ketamine can be good for these kids because it bronchodilates as well. And even up to inhaled anesthetics. So like Sevo or isoflurane, the gases that we use for anesthesia are really good at dilating the airways. So in severe cases, we can see that. All right, last section is trauma. So thoracic trauma. Mortality rate for this is quite high, usually just because if you have bad thoracic trauma, you have probably bad trauma in other places as well. So you can see head trauma, abdominal trauma along with it. It can be blunt or penetrating, but usually in kids, you're going to see the blunt traumas from NVCs or something like that. Kids have again, compliant chest walls. So their mediastinum is mobile, everything's more compliant. So sometimes you can have damage that occurs, pulmonary contusions and stuff, that don't necessarily cause fractures of penetration because it hits them hard enough. They have enough elasticity for those, the chest structures to kind of give, but it damages their lungs, and you can maybe not see the fractures that you would see in an adult. So usually you're going to have blood loss and hypotension with this. So lung contusions, I thought I had rib fractures on here, but this is more common in children than adults, again, because as they're hitting, that the chest wall kind of gives in and can allow for some lung contusion. It's bleeding and edema into the alveoli. So that's going to make a VQ mismatch because that bleeding and edema is taking up space in the alveoli that air can't get to, which is going to lead to hemorrhage. If it's bad enough, it can lead to hemorrhage or an edema inflammatory reaction. So you're just going to observe them, give them diuretics as needed and watch them in case they need intubation. And I do have rib fractures. Okay. So fractured ribs, again, this occurs less frequently because those ribs are more elastic. So if you see fractured ribs in kids, especially the younger they are, it indicates a severe trauma. It can also have injury to their liver, lungs, spleen, anything that's under those ribs. If they're less than 3, you're going to suspect child abuse because, again, it's very hard to fracture a kid's ribs. The great vessels are usually not injured, but you want to make sure you evaluate them. And you're going to, again, if the trauma was severe enough to fracture the ribs, you're going to want to look for other trauma, especially spinal injuries. So manifestations, you're going to see pain on that side with movement, fracture or tenderness to the fracture site, probably bruising and edema. And then they like to ask questions about flail chest. Flail chest is where you have a section of ribs that kind of get fractured in 2 places so they can go in and out as a group. And if it's been that bad enough to do that, you're going to see that pulmonary contusion like we talked about. It's going to bruise the lungs underneath. But you're going to see that paradoxical chest movement with that. So if you have a question about some type of trauma that's occurred and one section of the chest is going in when the rest goes out, or vice versa, that's probably flail chest. So you're going to want to do pain management and then just, monitoring them. And that is all for the review. Any questions so far on that? I'm going to load up the practice questions. And again, this probably is going to take us till after 5. So if you need to go, don't feel bad. But I wanted to give us a chance to practice some of these because, to be honest, I feel pretty good about pulmonary, and there were still some pretty tricky questions. So once again, I've put the trickiest questions on here. There's some that aren't too bad, but I put more of the ones on here that I either got wrong or almost got wrong because I thought they were confusing. So we'll do the first couple and kind of talk through them, and then the rest of them I'll let you guys answer on your own. Okay. A 9-month-old born at 26 weeks, so a preemie, has grunting, tachypnea, and cool extremities. The following ABG findings are obtained on room air. pH is 7.07, PCO2 is 80, PO2 is 50, and bicarb is 7. These results indicate. So my initial reaction looking at this, just talking through it, obviously your pH 707 is acidotic. Your CO2 80 is high, so that's respiratory acidosis. But they are trying to compensate with your bicarb. But the other big picture on this is your PO2. It's only 50. So my initial reaction on this was to pick uncompensated respiratory acidosis because to me, compensated should mean they're closer to normal. But in reading this was the AACN's answer in their explanation. So alveolar hypoventilation. So that's defined as insufficient ventilation leading to hypercapnia, which is an increase in the partial pressure of CO2. So I think the reason that it's not uncompensated respiratory acidosis is because they are trying to compensate, but you can see from the CO2 and O2 both, being out of whack that the alveolar aren't getting ventilated as much as they should. So I thought that one was a little mean and tricky. So that's why I show it. Next, I'll let you read this. There's a lot of numbers here, but an intubated patient has the following ventilator settings. So their peak inspiratory pressure is 20, their PEEP is 5, FiO2 is 50%, 0.5, their rate is 15, end-tidal is 55, and their SATs are 92. Their ABG is showing a 7.2 pH, CO2 is 57, O2 is 90, and bicarb is 25. So what change in settings would best improve the patient's ventilation? So usually, I put this on here as an example of don't pick the first obvious answer. So usually you think ventilation, I think rate. Going up in their rate should blow off more CO2. And it will, but you want to look at more things here. So first of all, their SATs are 92% on 50% FiO2, and their PaO2 is 90. So if we do that PF ratio and divide the PaO2, which is 90, by their FiO2, which is 0.5, that gives us 180, which means this kid is in ARDS. So they're going to need, changing their rate might help in the short term, but with this SAT, they're going to need an increase in PEEP. So this is one where my initial reaction was to go for rate because ventilation is CO2, oxygenation is O2. So to me, ventilation should have been the rate, but this was their explanation of why it's PEEP. So they're most likely developing ARDS. To keep the alveoli open, you need that higher PEEP, which, so they say initially that rate will bring the CO2 down, but as their lungs stiffen, the people will be most effective at keeping the alveoli open and the CO2 down. Okay, those are probably the trickier ones, which is why I want to talk through them. But while you read this, I'm going to put this poll up. Okay. During pressure support ventilation trials, a 25-kilo patient is assessed for readiness to extubate. Which of the following would indicate readiness, meaning they are ready to extubate? So a PEEP of 8, negative inspiratory pressure of negative 15, FiO2 of 55, or a spontaneous tidal volume of 150.
Why?
Bella's eating my plant.
I couldn't stop it.
All right, closing it out. And while it's finalizing the answers, so a spontaneous tidal volume of 150. So the key here is that they are 25 kilos. So a spontaneous tidal volume of more than 5 per kilo is an indicator you're ready to extubate. Usually, used to we put our kids like on a 10 per kilo tidal volume, and that's been shown to cause a lot of volume trauma. So typically we're in the more of like 4 to 7, 8 range. Usually you don't want to get up much more than 8 per kilo, but a spontaneous tidal volume of 150 is math, which I just should have more, is 6 per kilo. So it's more than 5 per kilo. That's a pretty good tidal volume. All these others, honestly, I don't know the normal for negative inspiratory pressure, but a PEEP of 8 is not great for extubation. You want to be more like 5 or less. And FiO2 of 55 is not great either. You want to definitely be below 50, but if you're about to extubate, hopefully below 30. Yeah. Oh, full results. You all got it right. Good job. All right, next one. We load up here. And again, I can't see your answers, so feel free to guess, even if you're not sure, because there's still several of you that aren't.
That's all anonymous.
Yeah, it's all anonymous, so feel free to answer. There's only 10 out of the 17 in here answered, so feel free to try it. Okay. Which ventilatory parameters should be weaned first in a patient with BPD? Oxygen and peak inspiratory pressure, peak inspiratory pressure and intermittent mandatory ventilation, tidal volume and oxygen, or oxygen and intermittent mandatory ventilation. So I'll give you all a minute to answer. She gets up on the couch and goes over to where the plant is and eats it. Here's Belle for moral support. You can do it. Just breathe. All right, we'll close it out. A lot more of you answered that time. Thank you. The answer, most of you got it right, but a few got at least part of it right. So the answer is oxygen and peak inspiratory pressure, because in a kid with BPD, again, that prolonged oxygen is going to cause a lot of damage, and the prolonged pressure. So that's why those are kind of the two you want to get. So the ones who picked other things, you at least picked, there was, part of the right answer in there, but those are the two most important things. So supplemental oxygen can have a toxic effect on the child's body, and the oxygenation is affected by other ventilator settings. So FiO2 is usually the first thing to wean, and then their lung compliance can be variable, especially when they're sick. So they're probably going to need higher PIPs when they're sick, and you want to get those down as soon as you can. So here's the next one. Load up. Okay, so ventilator settings for a newborn with persistent pulmonary hypertension of the newborn are pressure control of 22, PEEP of 5, rate of 40, I time of 0.3, FiO2 of 60%, and their pH is 7.49, CO2 is 25, O2 is 175, and their bicarb is 22. So what adjustments, based on that gas, what changes are we going to make to their vent? Just want to see the plan.
Well, child. Just really happy with the leaves, though.
Great. All right. Start to close it out. Okay, so Most of you got it right, or we're on the right track. The answer is going to be D. So this one is a little confusing because 2 of the answers are in the right direction. It's just like, how far do you need to go? But hyperventilation can cause pulmonary damage. Respiratory alkalosis and hypocarbia is associated with myocardial ischemia. So you don't want to be too alkalotic for too long, because that can cause damage to your heart, decrease blood flow. So oxygen can be toxic and increase your pulmonary vascular activity, and ventilator adjustments should be incremental. So the biggest thing on this one is, yeah, I mean, their PaO2 is super high, 175. So we definitely need to come down on the O2 because they're above 60%. We don't want to keep it, too high. And their rate's at 40 right now. And their bicarb's only, their CO2 is only 25. So they're a little alkalotic. So we definitely do want to decrease their rate so we're not blowing off so much CO2, and we want to decrease their oxygen. And the key on this one is that this is a newborn with pulmonary hypertension. These kids are very tenuous and twitchy, and you want to go slow on their weaning. So that's why you're only going to go down to 35 on the rate and 50 on their FiO2. You don't want to go too fast, too quick, too far, too quick. I don't know, I said 2 things the same. Anyway, you want to wean incrementally, wean slowly, especially with a baby with pulmonary hypertension. All right. Next question. All right. An infant with respiratory distress syndrome, RDS, is requiring mechanical ventilation, and those are their settings. They suddenly, so the PIP is 34 and the PEEP is 10 in an infant. They suddenly desaturate and become bradycardic, which is the most likely explanation. Go ahead and make your best guess. Okay, I'm going to start to close it out. All right, mostly the right one, and the couple tricky ones are the ones that got a couple of you, but it is a pneumothorax. So the key here is you're looking at those pressures. 34 over 10 is a lot, especially for a baby. So with that amount of pressure, you're at a high risk for rupturing their alveoli, which is going to cause a pneumothorax. Pneumomediastinum is not a bad guess, but pneumothorax is more likely in that situation. And a mucus plug was one that I kind of was toying with when I picked it. I actually might have picked mucus plug because, they have respiratory distress syndrome. If they suddenly desaturate, usually you're thinking, oh, suction, it might be a plug. But the key here is those high pressures are indicating that they're at a high risk for a pneumothorax. So. Okay. A patient's admitted to the unit after a witnessed episode of seizure and vomiting. Initial assessment reveals increased work of breathing, tachypnea, diminished breath sounds, increased oxygen requirement. Chest x-ray has evidence of bilateral pulmonary edema. What should you suspect? And there's probably a couple things you suspect. To me, this one was tricky. It had 2 answers I wanted to answer. Okay. Closing it out, so just a few seconds to let you answer. So yeah, it looks like most people were between the 2 that I was between, and I think I might have picked the wrong one as well. I think I picked foreign body aspiration because if they have a seizure and vomit, they've obviously, and they have this afterwards, it sounds like aspirated. But the The difference here is that they do appear to be quickly going, that aspiration with that gastric contents is quickly turning into an ARDS, like an aspiration pneumonia going into ARDS picture. So the key here is that pulmonary edema and breath sounds and oxygen requirement. So while they did aspirate something, that's kind of why when I was talking about aspiration, I said I had to kind of separate in my head as far as like a thing they aspirated or, a bigger aspiration that causes other problems. So if it had said aspiration pneumonia, I think that would have been even trickier. And I still think that this is a tricky question, but that's why I'm showing it to you, because these are, again, not written by me, written by AACN. Oh, let me show you the results so you don't feel bad if you got it wrong. So, okay. Okay, an infant presents with abnormal vocalization, persistent stridor, and difficulty with swallowing. The nurse should anticipate. And I'll admit, I probably should have gone back and put it in after I put a question. I didn't specifically talk about this problem. So don't read more into it than it says. Just abnormal vocalization, persistent stridor, difficulty swallowing. Yeah, I still, like, reading back through it, I still don't like this question. I still kind of disagree with what.
I don't like any of the answers for it.
Yeah, all of the answers are, I just think they're tricky. What it's getting at.
But it kind of goes back to the basics of, like, not jumping to something. Like,
yeah,
starting with a minimal intervention.
Yeah, it really goes back to, like, not reading more into it than what it gives you. And because all of you said racemic, which is not bad. I mean, you think stridor, you think racemic. And the problem is what they're getting at is vocal cord paralysis, which I didn't even include in the review because it's not like on any of the test plan and stuff like that. But it obviously happens. If infants with vocal cord paralysis present this way, obviously with this set of symptoms. So this is one of those times when you can tell test makers make a question and like they have a certain thing in mind when they're writing it, and don't realize that for a person just coming into this test where you've read about you've read about 10 different things that have these same problems. Because I saw this and I'm thinking epiglottitis, which, none of these really follow the typical epiglottitis thing. So y'all all picked racemic, which is a good choice. And I can't remember, I might have said racemic, and I was even like looking like, should we look at an emergency trach? Yeah, I think I picked emergency trach because to me, based on the review, materials that I got from AACN, this almost sounded like that's what they were heading towards. But that's because I overthought it. It doesn't say anything about drooling or tripoding or anything. I don't know. I just think this is tricky and I still don't like this question, but I include it just to show you to really like not read too far into it. Just take the minimum intervention. So an infant with vocal cord paralysis is going to need thickened liquids. Usually they grow out of it. Symptoms resolve around 6 months. You don't usually need medications and tracheostomy, but it was hard to get that that's what they were getting at, I think. So sorry to trip you up, but I did the same. And I was even more extreme. All of y'all were like, oh, just racemic. And I'm like, trach him now. So, okay. A patient admitted following blunt chest trauma reports stabbing substernal pain and shortness of breath. On exam, the nurse notes a crunchy noise that is synchronous with the patient's heartbeat. Findings are likely due to. Aww. He just looked guilty. All right, I'll start to close it out. I'll give you a few seconds left to respond if you've started already. And this is one that, even though in the review I didn't specifically mention Hammond sign, which is that crunching noise that's synchronous with the patient's heartbeat, you can still, figure out from context what it was, and most of you got it right. It's a pneumomediastinum. Obviously, you can tell blunt chest trauma. They probably have air going in somewhere, so it's just where's it at. And if you know Hammond sign, great for you. If not, you just had to kind of figure it out, and most of you were able to. But if not, don't feel too bad. It's substernal pain, that could be pneumopericardium, it could be any of these things, but pneumomediastinum is the correct answer. So, next, I've just got 5 more. Okay, the nurse reviewing an infant's record of apneic events noticed an increase in episodes requiring bag mask ventilation. So what additional assessments during these events would support recommending continuous positive pressure ventilation? So is it a decreased respiratory rate, prone position, feeding occurring, or noted color changes? I just thought this was written weird too. So she's going back and looking at the events after they've happened. And so what things happening during the events would mean they probably need continuous positive pressure. Okay. Decreased respiratory rate is not a bad guess because these are apneic events, but the one most concerned, you can kind of, that's already happening, right? Because they're going apneic. So it's noted color changes. So if you're actually seeing cyanosis or duskiness along with the apnea events, that's the biggest indicator that the apnea is really affecting, their hypoxia, and which is going to have impacts on their brain development and everything else. So that's the most concerning thing. Okay, a child is admitted after near drowning incident. The patient is being managed, and we'll talk a lot more about near drowning when we do multi-system review, the last one, I think. So they're on mechanical ventilation, but assessment reveals bilateral lung sounds, crackles, frothy secretions, ABGs, pH 7.35, CO2 45, PaO2 58, bicarb 24, and a base excess of -1 with a SAT of 89. So what would you anticipate? She won't stop it. Maybe I moved the plant back. I tried to put the plant where you can kind of see it, for background, but then she can get to it. So
leaves everywhere.
Great. Thanks, Bill. A lot of you haven't started it yet. I'm gonna go ahead and close it out so we can finish up, because I have to work tonight. Okay, so if it's near drowning with this lung sounds, frothy secretions, crackles, think pulmonary edema. And what helps with pulmonary edema is PEEP. Also, you can tell they're not getting great oxygenation because of their O2 and their SaO2 or their SATs. So, you could think FiO2, but PEEP is going to help with the pulmonary edema, which is going to help with your oxygenation. So to increase that functional residual capacity, which all of that helps with oxygenation. Nobody picked FiO2 of 100, and that's just too much. If you don't need to do it. The pressure support to 10 is not bad, but again, PEEP is just going to be better. It's better for oxygenation and pulmonary edema than pressure support is. Pressure support increases the tidal volume, but increases that functional residual capacity, keeps the alveoli open. Okay. preterm infant, A preterm infant in an isolate is experiencing apnea. In addition to maintaining a neutral head position, decreasing stimulation, what else should you do first? Keyword is first. And I kind of thought this one was worded weird as well. Of course, I did these questions without having gone and studied or reviewed apnea prematurity at all. But I was thinking they also like you're experiencing right in the moment. But I think they're just saying a preterm infant that in general has apnea prematurity. So as you can see from the first two things they mentioned, it's aimed more at prevention than actual intervention during an apneic event. So give a few seconds for you to finish up. And so the correct answer then is to lower their isolate temperature. So you want to make sure they're normothermic, they're not getting too warm. Again, your triggers or clues in this question is that they're talking about preventative measures, not necessarily intervention. So I think I picked bag mask just because I'm like, oh, you need to stimulate them, but it's lower the isolate temperature. So the main things for prevention are neutral head position, make sure they're not obstructing. In addition, avoiding triggers and stimulation, and maintaining a neutral thermal environment. Lower end of neutral thermal. Okay. Couple more. All right. A 4-year-old just admitted for asthma exacerbations receiving continuous albuterol at 5 an hour. Assessment reveals absent breath sounds, lethargy, inability to speak. Their heart rate 65 in a 4-year-old, respiratory rate of 10, SATs of 85. So what you would recognize this as an expected assessment requiring ongoing monitoring, an acute deterioration requiring an increase in their albuterol dose, a life-threatening emergency requiring intubation, or a concerning finding requiring administration of salbutamol. Wow, only one person hasn't answered. Who's the one person? Maybe you're driving. Oh, in progress. Everybody answered that one. Great participation. Thank you. I'm so excited. And almost everybody got it right. A couple people, there's plenty of room to go up on that albuterol dose, but the absence of breath sounds, the lethargy, and the inability to speak are all very concerning. So this is where it's progressed too far into that life-threatening emergency. So the increased albuterol is too little, too late kind of thing. So most of you got that right. Thank you all for answering and giving it a go. All right, last question. Okay, a child is admitted following an MVC. During initial evaluation, the nurse notes the chest wall on the left is drawn inward during spontaneous respirations and outward during exhalation. Injury most commonly associated with this phenomenon is. So this is one where it's not asking you what that phenomenon is. It's asking you what's the injury associated when that thing happens. So you kind of have to know what the thing is they're talking about and then figure out which of these is associated with that thing. They like to do this a lot. They don't ask you the answer, they ask you the answer to the answer. Everybody did that one too. I'm so happy. Finish strong. I like it. Okay, so the answer, and you could probably see any of these with that. It's talking about a flail chest. So again, that section of their chest wall is going in during, when they breathe in, your chest should go out, it's going in and it goes outward during exhalation. So it's got that paradoxical movement. So it's talking about a flail chest. And the most common injury associated with this, I think I got this wrong too. I was thinking pneumothorax because obviously if you have fractured ribs, you can easily cause a pneumothorax. But the key is that a flail chest is a big section of ribs, and so many with such force that it's fractured their ribs, it's probably caused that pulmonary contusion underneath. So it's most commonly associated with flail chest, and it's the primary source of hypoxia they have. So y'all were kind of evenly split between those two choices. And like I said, neither of them are bad choices, and I think I went for pneumothorax too. But it's just because with a flail chest specifically, so many broken ribs is going to bruise their lungs underneath. So, but good job. So hopefully, again, not all the questions are this bad. I intentionally picked some of the trickiest ones. So don't get disheartened like I was with some of these super tricky things. But that's all I have for today. And if you guys have any questions, let me know. And if not, so next week is Labor Day on Monday, and we're going to leave that time for either work or family or friends. So we'll do next week is when we start picking up Tuesdays instead. And I think the last one that I added on because of pushing this week back is going to be a Thursday just because of my schedule that week and not wanting to make sure I get sleep. So yeah, next week I'll see you guys on Tuesday at same time, 3 to 5 p.m. And we're going to talk about endocrine, GI, renal, that kind of stuff. So thank you guys so much for joining me today. I appreciate it. And I will see you next week.